This program is brought to you by Emory University.
Good morning, everyone. Thanks for tuning in. Our speaker this morning is Dr. Aneesha Thobani. Aneesha is one of our first-year clinical track fellows. She is a native of the Atlanta area, Emory undergrad, Mercer for medical school, then came here for residency. So many of you maybe know her from her days as a resident here. And she is going to talk to us this morning about cardiac amyloidosis. Thank you, Aneesha.
All right, thank you so much. Can you hear me okay?
Yep.
Okay, great. So good morning, everyone. Thank you for joining this talk, first of all, and thank you, Dr. Williams, for the introduction. This talk was actually inspired by a case that we recently saw just last month at the VA on the consult service. All right, so I think more people will be rolling in through the hour, but to those of you that are logged on, I want to encourage you to stay until the end because we do have a guest speaker. I have no disclosures to report. Okay. The overarching objectives of this talk, which is geared towards fellows, is to obtain an understanding of cardiac amyloidosis, look at imaging that is used for diagnosis, and explore treatment options that are approved and in clinical trials. So we'll start with the case presentation of our patient. Mr. R, he's a 73-year-old African-American male veteran who reports being generally very healthy. He walks 2 miles a day, works in the yard, and has not seen a doctor in years, he says. He does have a past medical history of partial seizures. He's not on any medications. He presented actually with progressively worsening dyspnea on exertion, fatigue, and bilateral lower extremity edema, all of which he says has been going on for about 2 months and worsened in the last 2 weeks. He says he's unable to walk 50 feet or lift anything heavier than 20 pounds. Pertinent negatives that included, he denied any P&D, paroxysmal nocturnal dyspnea, any orthopnea, any palpitations, pre-syncopal or syncopal events, or any neuropathy symptoms. As you can see, he's generally healthy, no medications except Tylenol as needed. He had no personal or family history of cardiac disease. He did report to drinking alcohol previously, but he quit 1 year ago and said he was never a big drinker. He denied any tobacco use, illicit drugs, including cocaine, any herbal supplements, and had no prior surgeries. On admission, his vitals, he was afebrile, pretty much normotensive at 130s over 70s, respiratory rate 17, but bradycardic with a pulse in the 40s. His exam, the remarkable findings included jugular venous pressure of about 11 centimeters of water, 1+ pitting edema bilaterally up to the mid-calves, and an irregular rhythm. There were no abdominal findings, and he was warm and well perfused. And since we're in the COVID era, I'll go ahead and mention that his COVID was negative. Initial labs, his troponin was high at 1.52. It came down to 1.42 subsequently. BNP was 1101. The chemistries, as you can see, are pretty unremarkable. His creatinine's normal at 1.12, normal potassium, and then his CBC is pretty unremarkable as well. Platelets of 192 and a crit of 41. Some more initial labs, normal LFTs, TSH was within normal limits, HIV is negative. The globulin gamma gap is 3.4, which is in the normal range. The only remarkable finding is this mild elevation in LDL cholesterol at 129, which is just at the higher end of normal. Okay, so before going further with this case, let's take a few minutes to learn about amyloidosis. So amyloidosis is a general term for a group of diseases in which a protein-based infiltrate deposits in tissues as beta-pleated sheets, as you can remember from medical school. These are termed the amyloid fibrils, which are insoluble, and these deposit in the extracellular space of organs and tissues. So when this affects the cardiac system, the deposits aren't happening in the myocytes, but rather in between the myocytes. There are about 30 different types of amyloid precursor proteins, as you can see here, that determine the subtype of the disease that manifests clinically. I'm not going to go through all of them. We'll focus on the cardiac ones only. In about the last 20 years, we have learned that cardiac amyloidosis and its resulting toxic cardiomyopathy is much more common than previously thought. It's not necessarily a zebra of a diagnosis. It is recognized as a cause of heart failure, especially diastolic heart failure in the African-American population. So in this talk, we will focus on cardiac amyloidosis and the 3 subtypes that affect the heart, being AL and the 2 types of ATTR, which are the variant and the wild type. Quickly about nomenclature, I'm not going to go through detail, but I do want to mention that the nomenclature is basically based on the precursor protein, and there are more than 30 of them. The V or the M at the end of ATTR refers to variant or mutant. The most recent guidelines use V for the variant, so I will stick to that terminology for the rest of the presentation just to be consistent. All right, so these are the most recent guidelines released by the AHA for cardiac amyloid, and these were actually published just a few months ago in July 2020, right when I started fellowship. So majority of this talk is based on these guidelines, and I would encourage you to take a look at them when you have some time. So in this talk, we will start with briefly going over AL first. It is the most common form of systemic amyloidosis. It also affects the heart, and I think that's why it's important to have a general working understanding of AL. AL is caused by misfolded monoclonal immunoglobulin light chains. So think of the plasma cell as the factory for production of these light chains. In patients with AL amyloid, a plasma cell clone forms and secretes these excess light chains. The organs that are most commonly affected by AL deposition are, number 1, the heart, kidneys, and liver. And the autonomic and peripheral nervous systems can also be affected. In AL amyloid, as you can see from the cycle diagram, the resulting cardiac dysfunction, it's not simply due to the amyloid deposits between the myocardial cells, but rather the circulating free light chains are known to be directly toxic to the myocardium, and they can have a cytotoxic effect on the cardiomyocytes, also resulting in apoptosis. All right, so AL affects males and females almost equally, and the age of onset is about 40 to 80 years. Some of the extracardiac manifestations that include the kidneys. You can have albuminuria, proteinuria, nephrotic syndrome, and potentially even renal failure. It can affect the liver. You can see elevations specifically in ALK phosphatase. When it affects the GI tract, it can cause, dysphagia or constipation, even GI bleeding. AL can especially affect the nerves, leading to peripheral neuropathy and autonomic dysfunction. And then these 2 that I have bolded, which is the tongue, macroglossia, and the periorbital purpura, are pretty unique to AL. And the periorbital purpura is actually pathognomonic for AL. In my short training, I haven't seen it yet thus far, but we'll keep a lookout for it. So AL amyloid is a rapidly progressive disease with a high mortality. If diagnosed, you want to refer, as soon as possible to your hematologist at Emory, because now we have chemo regimens such as Cyborg-D and even like stem cell transplant as a last resort for these patients. So if AL is diagnosed, asking for help soon in this case is very crucial. And your hematologist will be able to guide you and help take care of these patients. For the rest of the talk, I will mostly focus on ATTR. Okay, so transthyretin amyloid is ATTR. It's called transthyretin because it transports thyroxine and retinol, more specifically the retinol binding protein. ATTR can be inherited as an autosomal dominant trait, and it can be caused by the pathogenic variant, which is the ATTRV, or by the deposition of ATTR wild type, which is the misfolded protein. The ATTR wild type was previously called the senile cardiac amyloidosis. And I think, I don't think any patient wants to hear that they have a senile form of something, even if they're 70 years old. So the more correct and diplomatic nomenclature now is the wild type. This protein is mainly produced by the liver, as you can see in this picture. And it circulates predominantly as this homotetramer, this 4 subunit protein, with a small amount of transthyretin actually circulating in its monomeric form. And it's this monomeric form that is prone to misfolding, and it gradually deposits as the amyloid fibrils over the years, eventually leading to diastolic dysfunction, restrictive cardiomyopathy, and heart failure. Okay. So let's break it down. Let's talk about ATTRV and ATTR wild type separately. So the variant type, it is autosomal dominant with a variable penetrance. There are more than like 100 mutations that exist, I believe. Patients with the mutant or the variant ATTR are born with this pathologic mutation in the transthyretin gene, which leads to accelerated amyloid deposition. In the United States, the most common mutation is the valine 122 isoleucine mutation, often abbreviated as V122I. It's present in about 3 to 3.5% of patients of African descent. Now, the exact penetrance of the mutation is unknown, likely less than 10%, but this is almost certainly pretty underdiagnosed form of heart failure in African-American population. So ATTRV, the variant type, tends to affect males more than females generally. The age range of onset can be, anywhere from 55 to 75 years, pretty broad range. This table right here on the left, it's just showing a list of common mutations. You don't have to memorize this, but it's just an overview. The valine 30 methionine, the 2 mutations that are circled in the red box, the V30M, it's the most common mutation worldwide and the second most common in the United States, while the V122I, as I said, is the most common in the US, and was actually believed to have originated in West Africa. Okay, kind of want to mention here, survival curves for these patients when they're untreated. This study group looked at a cohort of 1,000 patients with amyloid in the UK National Amyloidosis Center Registry. 711 patients had the wild type form and 205 had the hereditary form. And they found that the median survival after diagnosis in untreated patients with like ATTRV is pretty grim at 2.5 years without treatment. That's your, that's your orange line. That's your orange line at the bottom that you can see. So median survival just below 40 months. The gray line in the middle, that's the curve for the wild type. And they found that the wild type had a median survival just above 40 months at about 4 years. So, pretty limited prognosis. Now, with the tools we have, we can make this diagnosis earlier and increase survival for our patients. So transitioning into the wild type. So the wild type, it mainly affects males, females very rarely, and the general age of onset is 65 to 95 years. The wild type ATTR is actually sporadic with no known markers. It's just, I think the transthyretin protein over a period of decades gradually, deposits as amyloid fibrils. And I think just want to kind of like put out there that the pathogenesis is still unclear and exactly what's happening to this protein for it to be sporadic. It's all thought to be due to like this destabilization of the normal protein. Some scientists have postulated that, this could be going on due to oxidative or like post-translational modifications, or even some chaperone proteins in the liver messing up. But I'm not going to go into the details of that in cell biology right now. All right, so looking at the clinical manifestations, in amyloid cardiomyopathy, extracardiac symptoms can usually manifest way before cardiac symptoms. So it's really important to know these, especially when you're building your index of suspicion and for screening. can present with neurological symptoms such as polyneuropathy. Patients can have paresthesias, weakness, also autonomic dysfunction, orthostatic hypotension, postprandial diarrhea, even gastroparesis, and like urinary retention and incontinence. Orthopedic symptoms, carpal tunnel syndrome is well known. You can also have lumbar spinal stenosis and unprovoked biceps tendon rupture and hip and knee arthroplasty. And I just want to clarify that the ATTRV, the variant, is more prone to having these neurological symptoms, whereas the wild type doesn't seem to present too much with the neurological and the autonomic symptoms. The wild type can have the carpal tunnel though. So that's one thing you do want to look out for, because the wild type, the protein can actually deposit in soft tissue, and that's why you're getting the carpal tunnel syndrome. Okay, so let's go through some of the cardiac clues that you want to keep in mind. And when you see this, it's going to help you build your index of suspicion and like figure out who to screen and whatnot. So just going to go through this. You know, these patients can often have intolerance to antihypertensives or heart failure medications because of symptomatic hypotension and orthostasis. This generally happens because the LV is very small, the stroke volume is limited, and when you give these patients general GDMT for heart failure, they don't tolerate it. They can have like a persistent low level elevation in serum troponin, often like 0.1 to 1.0, like a smoldering troponin. Our patient's troponin was 1.52, just to remind you. You can also see this discordance between QRS voltage on ECG and wall thickness on imaging. So we always learn that, you know, there's low voltage with ECG, with amyloid VC, but it's the discordance that you want to look for. And I'll get into that a little bit more. They can also have some unexplained, you know, atrioventricular blocks, or, you know, prior history of a pacemaker implantation and nobody knows the reason for it. And then on echo, you know, having unexplained LV wall thickening, right ventricular thickening, or atrial wall thickening. As it is with all things in medicine, we always want to keep a broad differential diagnosis. And I don't want to tunnel vision you into amyloid, so I wanted to put this non-comprehensive list up here. So there's a lot of things that can mimic, you know, the echocardiographic or the EKG findings. And just to name a few, you know, you can have hypertensive cardiomyopathy, restrictive cardiomyopathies, your infiltrative ones like sarcoid, hemochromatosis, the glycogen storage diseases like Fabry's disease. In this list, the two zebras that I can note are the apical HOCM that can look like this, and then the plaquenil or the hydroxychloroquine cardiomyopathy, which is pretty rare, and I personally haven't come across that. All right, so now we have reviewed some background, so let's get to making the diagnosis. This is a diagnostic algorithm published in the 2020 guidelines, and I will be referring to this diagram throughout the talk. So back to our patient, just to recall, Mr. R, you know, he's our 73-year-old presenting with symptoms of new onset heart failure. This was his first ECG evaluation. As you can see, it's showing a flutter with a slow ventricular rate, about 40s. Also some poor R wave progression that you can notice in the leads, and P wave inversion in the lateral leads. And you can also notice the low voltage in the limb leads. Just going to review quickly the potential ECG findings. So these are the things you want to be on the look for. Low voltage, signs of conduction system disease, like prolongation of the PR interval or QRS complex, even arrhythmias like AFib, A-flutter. And then sometimes you can also see these pseudo infarction patterns in these patients because the hypertrophy of the walls, and poor R wave progression is an example of that. Okay, let's get to some of the fun stuff. I'm just gonna make sure these videos are playing for you. Okay, so this is the echo for a patient. This is the parasternal long axis view. You can note the severe concentric left ventricular hypertrophy, the thickened myocardium. The wall thickness was measured more than, oh, sorry about that. The wall thickness was measured more than 14 millimeters for this echo. You can also note some RVHs present. We will also see that on some other views. And then the speckled pattern of the myocardium is very noticeable on these echoes, and that's a common association with amyloid. Also, the mitral leaflets are a little thickened, and we have this mild eccentric AI jet on the color Doppler on the right. I also want to bring your attention to the left atrium, which shows this layering echogenic structure, which is concerning for a tumor or a thrombus, or maybe even an artifact. All right, so all of these findings are suggestive of an infiltrative process. Here are the short axis views from our patient. Again, revealing the revealing findings we have mentioned already: the very thick walls, the speckled pattern, the reduced EF. This patient's EF was like 35 to 40%. And then here on the right, I just included that image. It's pretty cool because if you look at the color Doppler, on top of the anterior mitral valve here, you can see a tiny little, where's my cursor? A tiny little jet, and that's the AI jet that's kind of peeking through. All right, here are your apical four-chamber views. I just want to point out, anytime you see bi-V hypertrophy and dilated atria, it is a sign of an infiltrative process. And then again, in the left atrium, you see that big echogenicity, which could be a mass or a tumor. This is just a contrast image to drive home the point that it's reduced EF. And usually, in amyloid cardiomyopathy, a reduction in EF is seen in late stages of the disease. All right, so let's review a few common findings that you may see on echo, and that should make you more suspicious for amyloid. Findings suggest pleural or pericardial effusion, thick right ventricle, thick valves, restrictive LV filling, the speckled pattern that we have on our patient's echo, a thick interatrial septum, low stroke volume, and then oftentimes they can also have this paradoxical low flow, low gradient aortic stenosis. And then the apical sparing on global longitudinal strain is very well known and talked about in literature. So this global longitudinal strain is from our patient, Mr. R. In patients with AL and ATTR, the regional longitudinal strain is significantly reduced in the mid-ventricle and the basal walls compared to the apex. So you usually get apical sparing. Now, this is demonstrated by the characteristic polar map that you see here. It's often described as a cherry on top in literature. Or for our patient, it's not perfectly in the center, but I think it drives home the point, and you can definitely see the apical sparing of the strain with more involvement of the basal regions. Here's a better polar map. I just wanted to put in an image that shows the classic cherry on top pattern, so you can recognize it next time you see it. This image is actually from an AL patient that one of our fellows, Dr. Ray Quintana, saw, and he had published a review paper on this. So shout out to Dr. Quintana. Okay, so all these echo findings are wonderful and super interesting, but I want to emphasize that cardiac amyloid is not an echo diagnosis. A lot of things can look like amyloid on imaging and be something else. So if you look at this picture, it's from an article published in 2010. It's pretty famous. On first glance, all of these can look like amyloid, but they're not. So if you want to take a few seconds to look and kind of figure out which amyloid is, we can't necessarily have participation right now. So I'll kind of give you the answer. So in this image, the, C is actually cardiac amyloid. A is hypertrophic non-obstructive cardiomyopathy. B is hypertensive cardiomyopathy. C is the amyloid. D is mucopolysaccharidosis. F is, D is the mucopolysaccharidosis. E is cardiac oxalosis, and then F is Friedreich ataxia. Okay, so what do we do now? The next step, when you have a high suspicion and you see this on imaging, is to get serum-free light chains and serum and urine immunofixation electrophoresis, IFE, to rule out AL. You always want to rule out AL because that's a fatal disease. And if diagnosed early, you can send them to hematology and get them treated. A simple SPEP and UPEP that we are aware of is less sensitive, and it should actually be avoided. As you can see, the sensitivity of serum plasma electrophoresis for AL amyloidosis is about 70%, whereas the sensitivity of serum IFE is more than 90%. And then when you get all three of these tests together, the serum and urine IFE and the free light chains, the sensitivity increases to more than 99% to diagnose AL. Now, I recently learned that some labs have the IFE as a reflex order. So when you order SPEP and UPEP, and if they don't see M spike, the lab will not send it for IFE. That is the case at the VA. So you want to be aware of that at whichever hospital you're practicing at or rotating. So unfortunately for our patient, these are his labs, the SPEP and UPEP. The SPEP didn't have an M spike, so the report basically said it's not indicated, and Quest in Virginia did not send out the IFE. For a patient, the free kappa was elevated at 29.7, and the free kappa lambda ratio is elevated actually at 2.3. Telling of some type of light chain disease, and it makes it important to rule out AL in this case. All right, before we kind of go on with the diagnostic algorithm, let's kind of remind ourselves that our patient also had this, this mass or tumor or thrombus in the left atrium that we need to get sorted out. I'm just going to take a minute to kind of go through this. So cardiac thrombi are not a rarity in amyloid. It's not completely surprising for patients to have thrombi. This study had like 156 patients with cardiac amyloidosis. They all got TEEs, and they found that 42 patients out of 156, that's 27%, had a thrombus. AL amyloid had more frequent intracardiac thrombus than the other types. And then the risk factors as noted here for people who had thrombi were atrial fibrillation, AFib, poor left ventricular diastolic function, and a lower left atrial appendage emptying velocity, which interestingly, we do have for our patient. So our patient underwent TEE the next day. As you can see on the right, there's a lot of smoke in the left atrial appendage with a low emptying velocity. On the left is a bicaval view, and you can see the echogenic mass right here in the left atrium. Something that was concerning was when they did injection of contrast, it appeared that there was some perfusion of the mass, indicating that there's some vascularity, and then could this be a tumor? So let's pause for a second. So based on the diagnostics so far, we have a high degree of suspicion for amyloid, either AL versus ATTR, we don't know. Our KL ratio is greater than 2.0. And remember that echo cannot differentiate between the two types. And now we have this left atrial thrombus versus tumor, and we don't know what to do, and we need to figure out what this is because it will guide management. So this patient at this point has bought himself a cardiac MRI and also an endomyocardial biopsy. Okay, so this is the cardiac MRI sequence for our patient. He was actually transferred to Midtown for one day to get this cardiac MRI. Given the logistics at the VA, we couldn't accommodate it in a timely fashion. So a special shout out to all of our Midtown colleagues, especially Dr. Patterson and Dr. Eisner. So thank you for getting this done. So I've included one of the movie sequences. This is basically the money shot of the MRI. So this PSIR image shows the thrombus with negative signal, the dark right here, the dark negative signal in the left atrium. Also, there was no perfusion on delayed enhancement of the mass. So the cardiac MRI was confidently able to confirm that this is a thrombus and not a tumor. And I think I'm glad that we got this cardiac MRI for that reason. Also, on this same image, you can appreciate the delayed time image, which shows the delayed gadolinium enhancement in the LV and the LA walls. And this is pretty concerning or suggestive of cardiac amyloidosis. These are a few more pictures, screenshots from the cardiac MRI for patient Mr. R. These are all revealing basically delayed gadolinium enhancement. Now, I think one thing it's important to understand when doing an MRI for this sequence, you're basically trying to null the myocardium, meaning you're trying to make it completely dark. And when there is something present in the myocardium, it will not null, meaning it will not get dark. So you can see here the diffuse uptake of gadolinium in the left ventricle in the left ventricle myocardium, and also in the left atrial wall. And then these images also display the same thing. And then you also see the thrombus in the left atrium. And on the cardiac MRI, the septum was measured to be, I believe, about 24 to 25 millimeters. All right. I'm not going to go through this in detail for the sake of time, but this is just a differential diagnosis, an example of delayed gadolinium enhancement or late gadolinium enhancement. You want to have a broad differential, but for amyloid, usually the delayed enhancement is subendocardial, as you can see right here. And it will usually be circumferential, but this is kind of just showing you one little slice of it. Some other things that can look like this with subendocardial enhancement are post-transplant patients can have this, and then hypereosinophilic syndrome can sometimes present with that too. All right. So now some centers, especially academic centers, are doing this new T1 mapping, the T1 parametric mapping for amyloid, which produces beautiful images, and it can also help with early identification even before onset of clinical symptoms. So this is actually the parametric map for our patient, Mr. R. It was done at Midtown. And just to kind of explain it in simple terms, you look at all the red. All the red shows the T1 time sequence. So the colors correspond on the bottom to the lookup table, and the timing corresponds to the colors. So the red corresponds to more than 1100 milliseconds, which is abnormal, and the normal is less than 1040. So if it was more blue, that's normal. The red is abnormal. So I'm not going to go too much in detail, but for those of you who are interested in cardiac MRI, there's also this proposed calculation to determine AL versus ATTR, but this is still pretty novel. And so far, cardiac MRI cannot fully differentiate AL versus ATTR. But this was a great picture for us to have, especially for this talk. Okay, so the patient came back to the VA and he was already set up for a PYP scan. The PYP scan is the cheapest diagnostic imaging that we have, and that will tell us ATTR with most accuracy. Now, this is not for a patient. I want to quickly kind of explain to you how the PYP works, and then I'll show you the image for a patient. So it's basically a technetium pyrophosphate imaging. A lot of studies have confirmed the high sensitivity and specificity of PYP scans. PYP is just a tracer. It's used in the United States. Other countries use different tracers like the DPD. Planar and SPECT images are obtained, and then the analysis can be done in two ways. The first is this semi-quantitative visual, where you look at it and you compare uptake in the myocardium and the ribs. So grade 0 is no uptake in the myocardium and normal bone uptake. You can see the bones are lighting up more than the heart. Grade 1 is uptake less than the rib uptake. Grade 2 is equal uptake in the heart and the ribs. And then grade 3 is more uptake in the heart than the rib. So the heart is clearly lighting up a lot more on this grade 3 picture than the ribs. And grade 2 or 3 are strongly suggestive of amyloidosis. And in the absence, remember, in the absence of light chains, it can be used to make the diagnosis of ATTR without any invasive testing. Now, this is the image sequence for our patient. The planar CT images at the top right here. You can clearly see the orange and the yellow flame showing the high uptake of the PYP tracer. And then the rest of these images are comparing your tracer in the myocardium to the ribs. And this was read as grade 3 uptake at 3 hours, and it's strongly suggestive of ATTR amyloidosis. So I told you there were two ways to measure. The second way is a quantitative myocardial uptake analysis. So this looks at the myocardial, the H for heart, to the contralateral CL lung ratio of uptake at 1 hour. They basically draw these little circle targets, as you can see here. The left is for our patient, and the right bottom is just an example from the ASNC guidelines. They basically draw these circles and they measure mean counts within those circles to obtain an H to CL ratio. A ratio of greater than 1.5 is classified as ATTR. and it's positive. And for our patient, as you can see, it was 2.8. So pretty telling of ATTR. Okay. Our patient actually ended up having an endomyocardial biopsy. A couple of reasons to pursue this. Number one, we had this free light chain ratio of like more than 2, which was concerning. And we're like, okay, we have to rule out AL because there can be concomitant disease. And then number 2, a lot of insurance companies and even the VA ask for biopsy results before approving these expensive therapeutics that we have now. So this is just showing you the bioptome and then the right heart biopsy, getting a little specimen from the septum. All right, let's look at these pathology slides. Now, these are actual pathology slides of our patient, and I want to thank Dr. Lau at the VA for getting these images. Right here is a zoomed in H&E stain. The yellow arrow is pointing to the amyloid deposits in between the myocytes. The pink are the myocytes. Now, I want to make sure. So you see the blue dots, those are the nuclei. Now, if you saw blue dots everywhere, that would be indicative of an infection process like myocarditis. In this case, we don't see that. So we know this is not like myocarditis or something else. And we clearly see the deposition in between the myocytes. We were also lucky enough to get the Congo red. This is simple to understand. The Congo red is staining all the amyloid. And then finally, this is the money slide, and Dr. Lau made this happen with his iPhone, and he did the polarized light with his phone. So this is the classic apple green birefringence, and I circled it there, and you can obviously pick that out. Normally, there shouldn't be any birefringence in tissue, and this is pretty diagnostic of amyloid. Okay. And then we recently got the SPECT analysis from Mayo after 3.5 weeks, and they confirmed ATTR, transthyretin type. And interestingly, they did genetics, and our patient has the valine 122 isoleucine gene detected by mass spec. And then, yeah, the Congo red was positive. I had my bet on wild type given the age of the patient and the clinical presentation, but this did surprise me a little, and I think it makes for a more interesting talk. Alrighty, so let's move on to therapeutics and management. Remember this picture I showed you earlier? It's basically showing you that the protein is made in the liver. It exists as this, tetramer. It can get disassociated into dimers, and then it misfolds into these amyloid fibrils. So if you can target any one of these processes, you can make a drug. Now we have 3 classes. We have suppression of TTR, which are often called the silencers, which include patisiran and inotersen. We have TTR Stabilizers, which are, Tafamadis, which recently got approved, and diflunisal. And then you have TTR disruptors, which are doxycycline, TUCA, and these monoclonal antibodies that are under clinical trial right now. So I'll briefly talk about some of them, and we'll spend a little bit more time on Tafamadis. So TTR protein silencers basically target the hepatic synthesis of TTR. So both patisiran and inotersen had a result of more than 85% reduction in the circulating TTR protein concentration. There haven't been too many studies about this. There are 2 drug studies. Both of them had a pretty small sample size of 225 patients, but they did have some promising results. The Apollo study did show that, there was reduction in neuropathy impairment and polyneuropathy disability for the variant type for the patients who actually presented with neuropathy symptoms. And it also showed a reduction in the global longitudinal strain. So I just kind of want to point that out. And then there's another small inotersen study that showed stabilization of LV wall thickness. And I think they also had like a decrease in the 6-minute walk test and showed some reduction in global systolic strain pattern. Some TTR silencers on the horizon. There are a lot of studies going on looking at more silencers. Just kind of want to point this out to you so you can be on the lookout for this. There's about 4 trials going on. One's with patisiran, there's another one with inotersen, and then Helios-B is another silencer, and then the CardioTransform is this AKCEA TTR drug that they're testing in transthyretin-mediated amyloid. Okay, moving on to the stabilizers. So diflunisal is an NSAID that stabilizes TTR in vitro. It's not been studied too much. There was this one little randomized study of 130 patients with ATTR-V and polyneuropathy, and diflunisal was associated with a reduced progression of polyneuropathy, but there are like no major randomized clinical trials for this. And also you want to keep in mind, diflunisal is an NSAID, and it can actually cause harm and can worsen heart failure exacerbation and kidney functions. It's used pretty rarely in very specific centers, and I personally haven't seen it being used. Okay, so now getting to the ATTRACT study. This was published in 2018. This study was testing Tafamadis, and this drug was approved by the FDA in May of 2019, so almost just a little over a year ago. So remember that the Tafamadis, it binds to that transthyretin protein, and it prevents and stabilizes the tetramer dissociation. So you have less monomers happening, and if you have less monomers, they will fold less. Okay, so a little getting into the details of the study, they enrolled 441 participants with either ATTR-V or ATTR wild type, and this was with a confirmed diagnosis by biopsy. It was double-blinded, and they randomized patients to receive either 80 milligrams of tafamidis, 20 milligrams of tafamidis, or a placebo for 30 months. The primary outcomes were all-cause mortality and frequency of cardiovascular related hospitalizations. And their secondary outcomes were change in 6-minute walk test and the Kansas Quality of Life Questionnaire. As you can see, the results are pretty striking. It showed that tafamidis was associated with a significantly lower all-cause mortality, 29.5%, about 30%, with a combined 20 and 80 milligram dose versus 42.9% for the placebo group. And also lower cardiovascular related hospitalizations per year after 30 months. The study also met its secondary outcomes, secondary endpoints, showing that tafamidis was associated with a lower rate of decline in the 6-minute walk test and a lower rate of decline in the Kansas City Cardiomyopathy Questionnaire. So these are pretty practice-altering trial with a very strong data. A 30% reduction in the risk of all-cause mortality compared to placebo is pretty significant. And the number needed to treat for this all-cause mortality is actually just 7.5, which is incredible. So, just think about this, and it tells us, that we can do a lot of good if we diagnose early and start treatment early. Here's a forest plot, basically from the same ATTRACT study. This is highlighting that, basically everything favored tafamidis for survival analysis and for the CV hospitalizations. Class 3 NYHA symptom patients did not fare so well with the hospitalizations on the right, as you can see. Where's my cursor? Right here. And, but these patients could have also been more sick at the beginning of the trial. I also want to draw your attention to this circle that I have drawn over the 80 and the 20 milligram dose. There weren't, significant differences in the dosage. So institutions use either dose. At the VA, I found out that the dose is 20 milligrams. Now, I know this is all great data. I'm not saying that tafamidis is a miracle drug. We don't have long-term data yet, as this was, just approved a year ago. But so far, it's the best results we have and an FDA-approved therapy. So who knows? Maybe in the future, the silencer drugs may reveal more benefit. I think we may even have like a study at Emory that's starting with the silencer drug. And in the future, we may very well be treating this disease with a combination drug therapy approach. All right, I'm going to quickly mention these TTR disruptors. That's another point that you can inhibit. Again, not enough evidence for any of these, but rather there were some side effects and that were noted with the doxycycline plus TUDCA. And then lastly, this PRX004 is the first monoclonal antibody that's under investigation currently. So we'll see if, monoclonal antibodies have a role with amyloid. Alrighty. So with me being a PCP at Grady during residency, Grady really taught me to be cognizant of cost. So I wanted to kind of delve into and look into how much all of this costs. Your cheapest option is diflunisal at $60 per month. But remember, there are a lot of limitations with diflunisal, and it is an off-label use. Now, the other three come with insane prices that can either, buy you a house in the suburbs at 225K, right outside the perimeter at 360K, or inside the perimeter at 415K, or maybe a townhome inside the perimeter. But jokes aside, how our patients will afford this is a huge challenge and an area of interest. It's great that we have therapies now, and we can make the diagnosis, but how do we get the medication to the patients is a challenge. So a couple of pointers for those of us who are in the VA, Grady, Emory system. At the VA has Tafamidis. The VA pays $3,500 per month for the 20 milligram dose. But the cost to the patient is between $14 and $21, which is amazing. And that's just based on their service connection. So a patient can pay $14 per month and be treated with Tafamidis at the VA. At Grady, we recently got Tafamidis. It is available, and you can contact our pharmacist, Mary Catherine Sheely, who is phenomenal, and she will help you get Tafamidis for your patient. As far as the cost to the patient, what I understand is that the patients will still just pay their regular copay for the drug. So if they're on the Grady card, they might only be paying $4 or $5 for this drug. And I'm not sure how much Grady is paying, but we could find out with some digging. But I'm just glad the patients can get this at a low cost. Okay, so let's kind of circle back and end the talk with our patient, Mr. R. So ultimately diagnosed with ATTR-V, the mutant or the variant form. He had the classic mutation with the valine 122 isoleucine found in African Americans. He's currently on a DOAC, and he was also cardioverted as outpatient, and now he's in normal sinus rhythm. He will be starting Tafamidis through the VA, so his paperwork is underway. And we'll be discussing family screening at his next visit, because if he has this genetic variant, what I do remember is Mr. R actually has children. So for his children to get screened is something to keep in mind. All right, so in summary, if you weren't paying attention, this is a time to come back. Okay, so I thought at the end I could just tell you to read those guidelines as a summary, but then I thought, what could be better than this? So we have the writing committee chair, Dr. Michelle Kittleson, who has recorded a summary of this presentation for us. It's 3 minutes, and I'll play it for you now. Oh, you share.
Hi there. I'm Michelle Kittleson, a cardiologist at Cedars-Sinai, and Dr. Thobani asked me to give you some high-yield tips and tricks regarding cardiac amyloidosis. So I have 2 slides to show you. First, when it comes to amyloidosis in general and TTR, transthyretin in particular, you have to have a high index of suspicion. So I think of it kind of like a tip of the iceberg phenomenon. So you might see heart failure symptoms, and then it becomes basically pretty obvious to make the diagnosis. But what about the more subtler clues that something is brewing? Well, there's fatigue, cardiac symptoms such as atrial fibrillation, AV block, need for pacemaker. Aortic stenosis and HFpEF are important because a sizable minority of patients with these conditions actually have transthyretin cardiac amyloidosis, and increased LV wall thickness with discordant QRS voltage. So not necessarily low voltage, but discordant voltage. Also think about other places amyloid infiltrates. Patients may have a sensory neuropathy, autonomic dysfunction. Classic clue is you give them a vasodilator for hypotension and they get presyncopal. Orthopedic concerns, carpal tunnel syndrome, spinal stenosis. Patients often have these issues, surgery for these issues, years prior to the actual diagnosis of cardiac amyloidosis. Early diagnosis is key because with the currently approved therapy for transthyretin cardiac amyloidosis, Tafamidis, it only prevents progression. So you want to diagnose it as early as possible. When I think about the diagnosis, I like to boil it down to the 3 ± 1 tests you may need and the 3 possible diagnoses. So you're basically looking for AL amyloidosis or ATTR amyloidosis. And of those 2, it's either the hereditary, the variant mutant type, or the wild type. So you'll start with the clues from your history, your ECG, your echo. And that will lead to testing for monoclonal light chains and the technetium pyrophosphate scan. These are definitely done simultaneously, but they should be evaluated separately, meaning if you have positive monoclonal light chains, that sends you down the path of looking for AL amyloidosis, which requires a biopsy to make the diagnosis. If you have an abnormal technetium pyrophosphate scan, then you're thinking about ATTR amyloidosis and will then do genetic testing to figure out whether it's wild type or variant. A few important pointers about these diagnostic tests. When you test for monoclonal light change, do the serum and urine immunofixation electrophoresis, not SPEP, UPEP. These are not as sensitive, and a negative SPEP and UPEP does not exclude the possibility of monoclonal light chains. Second, when you do a biopsy, which you'll need to do if you find monoclonal light chains, then a fat pad is generally done because it's less invasive, but it is not as sensitive for ATTR. So if ATTR is on the differential, you're going to want to do a heart, perhaps a kidney biopsy, a biopsy of an infected organ. And finally, when it comes to the technetium pyrophosphate scan, if you remember nothing else, remember this. It's diagnostic for transthyretin cardiac amyloidosis only if the light chains are negative. If the light chains are positive, you might have false positive, you might have coincidental disease. So it's very important that if the light chains are positive, you don't stop until you have a biopsy. Well, thanks so much for your attention. I hope that's helpful. And now I'm going to figure out how to stop recording.
Okay, new share. Let's go back to the PowerPoint. Okay, so can you guys hear me now? I think it should be fine. So I definitely think, this is the money slide. If you want to take a screenshot and keep it on your phone as a reference for the future, I would highly encourage that. I already have a screenshot of it. So I'll leave this up for a few seconds. And I can always go back to it if somebody wants it. All right, so that's the end of the talk. I just want to say, thank everybody across the VA system and Midtown who has been part of, this patient's care. This just tells us how many doctors, cardiologists it takes to diagnose one amyloid patient. But I hope that after this talk that you will keep this on your differential diagnosis and build your index of suspicion and diagnose at least one amyloid patient in the next month or two. So thank you for your thank you for your patience and your attention, and I'll be happy to take any questions with the remainder of the time.
Thank you, Aneesha. That was great, and a minor miracle that all your media were. You got all the echo multimedia. That was fantastic multimedia presentation. Instead of a question, I just have a couple of comments. One is you raised this point, which is an important one about the EKG voltage. That right, it's a bit of a misnomer that low voltage is what we see. Like you said, it's often relatively low voltage. Depends probably on the stage of the disease. That those really low voltage EKGs that they'll often show on board exams are probably very late stage severe cases of cardiac amyloid. But you're right, it's more, you can have sort of normal voltage with high voltage on imaging. So it's more the discrepancy between the EKG voltage and what you see on imaging. And then in terms of the apical or the basal sparing of the strain, the basal low strain apical, one of the few times really as an echocardiographer where the strain is extremely valuable. I shouldn't say few, but definitely one of the most key times when strain imaging can be very potentially diagnostic or provide a lot of clues, because there's not a lot of other things that give you that pattern that you showed with the apical sparing a normal strain at the apex. So
hey, Aneesha,
anyone else, any other questions?
Hey, Dr. Bob.
Hey, great presentation, Aneesha, very thorough. And I wanted to just make 2 points for you. One was that this patient's light chains were abnormal. So is there a reason why we got a PYP when you knew you were going to do a biopsy?
So the sequence of events didn't kind of transpire I mean, they were pretty much as I explained, that we had already ordered this and he was on the way to get the PYP scan at the VA and we didn't stop it.
Got it.
It happened the same day he came back from Midtown, and yeah, so that's a small, something that you picked up, right?
Yeah, and I think it's not uncommon to see that because every order is put in at the same time, and sometimes the light chains don't come back for 3 days, but the PYP can get done the next day. But it's important, just as you've pointed out several times, that the PYP scan can only be interpreted if the light chains are negative. So if the light chains are positive in any way, then the PYP becomes a non-diagnostic test. That was point one. Point two was that when they get mass spectrometry at Mayo Clinic, which is where all our pathology goes, they're able to tell by the weight of the protein and some other sophisticated testing that they do, the most likely mutation that the patient has, but this is not equivalent to genetic testing.
Okay.
So this patient should still have genetic testing to confirm. Now, most of the time, this is more important when the patient comes back with a wild type diagnosis from mass spec. So meaning the mass spec did not pick up any protein abnormalities. And so we think it's the normal protein that's depositing. There was a good Hopkins paper that showed that in the wild type patients, when they did genetic testing, they actually found that 17% of them had mutations that were pathogenic for TTR amyloidosis.
Okay,
so the mass spec is not equivalent to genetic testing. And then just as a plug for our cardiac amyloidosis clinic, we are going to be part of the Helios B and the CardioTransform study. And yeah, great talk. Oh, last point. Tafamidis 80 is the FDA approved dose. If you're using not Tafamidis 80, you are using a non-FDA approved dose for the drug.
Yeah, I think due to cost reasons, the VA uses 20, but yes, I do understand that. Thank you.
Okay.
Yeah, this is Andy Smith. A few pearls. One is patients with end-stage renal disease often have an abnormal texture on their echo, and often the question comes up as to whether it's amyloid, and in general, it's not. The second is that when you see a patient who you think has HFpEF from hypertension and suddenly they start becoming hypotensive and developing these other things, think of amyloid. The next point is that as far as guideline-directed medical therapy for systolic heart failure, it does not apply to cardiac amyloidosis. All the systolic heart failure trials, including the defibrillator trials, excluded patients with amyloid, and you can actually make patients with amyloid much worse and hypotensive by trying to push beta blockers and ARB and ACE inhibitor type therapy on them. So those are just a few caveats. And then a final thing is for those of us who are older, back in the late 80s, we actually used pyrophosphate scans to diagnose myocardial infarctions 3 to 7 days after an event had occurred. So that's another false positive that you can get with a pyrophosphate scan as a recent myocardial infarction.
Thank you, Dr. Smith.
Hey, this is Raja Laskar. That was a fantastic presentation. If Dr. Bhatt, I have a question for you and Dr. Thobani. So for new onset diastolic dysfunction over the age of 60, should we be screening all of these patients with pyrophosphate scans and what have you? And do you think we're headed that way with the with obviously the pyrophosphate scans and obviously more therapeutics?
Dr.
Aneesha, do you want to try answering that first? I have an answer, but
let me just understand it. Oscar, you're asking, are we moving towards a direction of
well, my question is too, obviously, you know, we've gotten very good at finding patients who have obvious amyloid by echo, both by strain and by just pattern recognition. But my question is, besides patients who are being screened genetically, who do you think will be screening in 5 years for amyloid? And will it be kind of a blanket screening? I mean, just kind of thinking outside the box, or do you think we'll be screening more people who have just a little bit of LDH or what?
Yeah, I actually have a slide on that, and we have run out of time, so I won't pull the slide up. I had a slide on screening. So I think Mayo had tried to do blanket screening, and they basically were sending serum light chains and IFEs on everybody who had a suspicion based off of echo, and then they found that the yield wasn't as high. And if you want to use PYP as like a mass screening, I think the cost and benefit ratio might not add up. The way I understand it so far is that you need to have some degree of suspicion, because the echo I showed, that was pretty telling of amyloid, but there are other things that can present like this. So if your clinical history, your EKG findings, your echo, family history, and the clinical symptoms add up, and you have a high index of suspicion, then I think the patients deserve a screening. The serum light chains is very cheap, and then also they should get a PYP scan. It's not very expensive. So if you have any suspicion for it, I think they should be getting PYP scans, and that's like a first go-to.
Yeah.
What do you think, Dr. Bhatt?
So I'll second that. So Dr. Laskar, to your point, there are currently national trials going on looking at mass screening. One trial is designed to look for minority patients with HFpEF with mild LVH or greater, so septums greater than 1.2 centimeters, I think. So that's one way of thinking about screening, and we'll see what that study shows. And then there's another larger, just all-comer HFpEF trial looking to screen patients over the age, I think, of 65. And I think that's kind of where we're probably headed to, Dr. Laskar. In 5 years, I think if you have a patient who's of African or Hispanic descent, who's older than 55 with mild LVH, we probably will get a PYPs on most of those patients. Or alternatively, if you have somebody who's over the age of 70 with HFpEF, maybe we'll get a PYP. So yes, I think we are moving towards that.
So TTR amyloid is pre-albumin. Is there any thought that the pre-albumin blood test might be helpful in any way?
No, we haven't really found anything about that, and I didn't read too much in the literature about it.
Dr. Smith, that's a good point. So in patients who are gene positive for TTR, meaning the children of the valine to isoleucine patients, pre-albumin is something that I follow. Pre-albumin has been shown to indicate poor prognosis in patients who have known TTR disease and have a very, very low pre-albumin level. And so normal pre-albumin levels portend good prognosis, low pre-albumin level portend poor prognosis, and that's something I follow in our patients with TTR amyloid. And then that's something else that's looked at for disease response, as well as sort of for monitoring of gene positive but asymptomatic patients.
Well, obviously a very rich topic that we could probably go on all morning about, but for the sake of time, we'll wrap it up. Thank you again, Aneesha, for a wonderful. Certainly, Dr. Thobani and Dr. Bhatt are available for further questions if anybody has them. Thanks, everybody.
The preceding program is copyrighted by Emory University.